Welcome to the Pain Science Podcast, where we discuss science-backed ways to treat chronic pain. I'm your host, Dr. Joe Tata, a licensed physical therapist and founder of the Integrative Pain Science Institute, where we train practitioners in whole-person pain care. This podcast also serves as a public health campaign to support those living with chronic pain. This podcast is for informational purposes only and not intended to be a substitute for professional medical advice. Hi there, and thank you for joining me for this week's episode of the Pain Science Podcast. On today's episode, we're talking about ways to move primary care physical therapy into the mainstream. My guest is Dr. Justin Carrier. He is a physical therapist and the president of the American Physical Therapy Association of Utah. He played a key role in Utah's recent primary care legislative win and is focused on advancing physical therapy's role in primary care, improving access, and of course, future legislative progress across the state of Utah, as well as the nation. So on today's episode, we're going to take another deep dive into the role of physical therapists functioning as primary care providers for neuromusculoskeletal pain. If you could do me a favor and subscribe to the podcast on your favorite podcast player, that helps us reach more people with important messages like this one today. Okay, without further ado, let's begin and let's meet Dr. Justin Carrier. Hi there, Justin. Thanks for joining me this week on the Pain Science Podcast. I'm interested in learning all about the progress that the Utah Physical Therapy Association has made in primary care PT.
Yeah, I'm excited to talk about it. Thanks for having me.
Many physical therapists and obviously members of the public are aware of things like entry point practice and direct referral to see providers and direct access, which of course we have in physical therapy in almost every state now on some level. How is this different than what we've traditionally seen in the physical therapy profession?
Meaning our primary care legislation.
Yeah.
Yeah, so you mentioned that we have direct access now, I believe, at least limited direct access in every state. But I think one reason this is significant is because I think direct access is not a common term that people are going to understand, right? And so I think just kind of off the bat, I think it's important to kind of push this primary care term because that's language that the public relates to. No one knows what direct access means. They don't care what direct access means. But primary care, that makes sense to them, right? And so for us here in Utah, here's I can give you just a little quick history. It's been a couple years ago now. Our executive director and I sat down and we just said, like, payment. We can see APTA is doing some things to change payment, contrary to maybe what some might believe. They're doing a lot of work, but they're trying to push a huge stone up a very steep hill, right? What can we do locally on a grassroots level to do our part, basically? And so we decided to gather a group of private practice owners in our state that were members of our chapter, because quite frankly, and I fully acknowledge that our profession is more than just private practice, but these types of things probably affect private practice the most, so they have the most vested interest, right? So we got them together and we say, recognize we want to help. We recognize this is an issue. We want to, as a chapter, help this. What do you guys think the biggest barriers are? And one of the things that came out of that conversation was the specialist designation that physical therapy has within insurance reimbursement models. And it just so happened that maybe a month before, our executive director had done a little bit of research and found in state statute in Utah where the definition of a primary care provider was. And there were there were only three professions listed. There was physician, dentist, and I can't remember the other one off the top of my head, but it was another medical related thing. And so she kind of proposed, hey, what if we try and change this definition, get rid of this specialist designation, and get physical therapy recognized as primary care. So that's kind of where the whole thing started, and that's where it's quite different. And I've had this conversation with a lot of other chapter presidents. It's quite different because we didn't do it in scope, and I think we were expecting it to be. I'll just say we were pleasantly surprised that it went through in one go with no opposition. There was no opposition in either chamber of the legislature. In the committees, it went through unanimously, and it was a very pleasant surprise because we were getting ready for a battle. and it never came. And I think it's because we found this little bit of a back door that we didn't have to do it scope wise. It was through state statute.
That's interesting. I think it's interesting to just kind of review that just a moment, because I'd imagine obviously other physical therapists are listening to this and they may be involved in their House of Delegates in their state or
Mm-hmm.
maybe at the national level. But Utah, you as the president leading, approach this as there's some confusion maybe, or it's unclear to the public what direct access is, but the public does understand what primary care is. So
Yeah.
leading with those words are important, primary care. And then instead of going for a scope change, it sounds like it's if the terminology is correct, it's a legislative change. Is that correct?
Right.
Yeah.
Yeah.
And how does what's the difference between a legislative change and a scope change?
Yeah. So, again, I'm no expert on this, but from what I've seen and understand, I mean, obviously, a scope change, we'll start with what we all understand is like saying we want to make this change to our scope of practice, which everyone's always a little, nervous to do, a little hesitant to do, because that opens up not just for us to make a change, but that opens up for whoever else might have issue with it to also try and make some changes. Right. Versus this legislative statute change is really what it was, left our scope completely out of it. And we just, in this definition in state statute legislatively, added physical therapy to this definition, or physical therapist to this definition of what a primary care provider was and what primary care is, was physical therapy services. And so we were able to just completely circumvent any sort of that kind of iffy, I don't know if we want to go there, area of opening the practice at.
What are you doing? Do you have the education for this? Do you have the
Right.
skills, expertise? Can you do this safely? We've heard those things,
Right.
obviously on direct access, but I'm sure for primary care, those things start to go a little bit deeper.
Hmm. Yeah.
What does this mean for like the traditional referral based model of physical therapist care in, I guess, in Utah, but potentially other states that might go down this road?
Yeah, that's a great question. And maybe I'll answer it by kind of looking at it from s- we've gotten quite a bit of, a fair amount of feedback from our own members, but also as I'm having conversations with people nationally, like, why? Why do this? I don't want this. Right. I mean, you've mentioned some conversations you've had with others. They're like, we don't want primary care. And I think that my simple answer is it changes nothing really, which maybe sounds like, well, then why are we doing it? But here's the argument I have to those people that say, like, I don't want to do primary care. That's not what I signed up for. I think it's important to kind of distinguish and differentiate what we mean. Like, we're not saying we want to be primary care physicians. We don't want to manage people's diseases. We don't want to diagnose people's diseases. We don't want to do the things that our primary care physicians are doing. What we want to do is say, look, we are the experts when it comes to musculoskeletal management. And so we want to be primary care providers, not physicians. I think sometimes those words get mixed up a little bit. We're not wanting to be primary care physicians. We want to be primary care providers for musculoskeletal issues and injuries and diagnoses, right? And along with that, I would argue that every physical therapist who's in clinical practice does that every single day with every single patient already. Whether you want to call it that or not, anytime that we see a patient, we're making that decision: are they appropriate to be here, or do I need to refer them to somebody else? And that's really at a base level what primary care is triage, right? Should this person be here in this setting, or do they need different care? And that's, like I said, we do that all the time, whether they really think about it that way or not.
Yeah, because
And we're
we're
really good at it too, I want to add. Like, we're really good at knowing when someone should be in our clinic, when someone's appropriate for PT, and when they shouldn't be, and to refer them out.
right. So when you say we're good at it, the research obviously supports that.
Yeah.
As you're talking and you say, I appreciate you making the distinction, primary care providers for musculoskeletal conditions. So that could, and kind of fill in the blanks for me, that could run the gamut from acute or chronic low back pain to potentially someone, let's say, with Parkinson's or MS.
Yeah. And that's a good point to make, because we did, now it's been so long, but I feel like we actually, in the wording phrase it as neuromusculoskeletal, not just musculoskeletal, so that we could kind of catch us. Again, we don't want to diagnose Parkinson's, we don't want to diagnose MS, but if someone knows they have that condition and they need some physical therapy, then we know how to address that, right? And if someone comes into the clinic that maybe hasn't been diagnosed yet, we're not going to say, "Oh, I think you have Parkinson's disease." We're going to say, "You know what? I think you need to go see your primary care physician and perhaps a neurologist and figure this out a little more, and come back and let's work."
Yeah. The diagnosis piece,
Mhm.
interesting topic though, because
It is.
because I've read all the documents and I've gone from the APTA's documents, for example, their House of Delegate perspectives. I've read the APTA guide to physical therapist practice, and I probably have read almost all 50 state practice acts at this point because I've looked at topics like health and wellness and nutrition and psychologically informed care and mental health. So I'm kind of familiar with, at times, a mixed bag of terms that we have. Now, diagnosis is in our House delegate policies. Diagnosis is in certain state practice acts, and diagnosis and differential diagnosis, which I think differential diagnosis is actually the more important one, is in our
I agree.
guide to PT practice. So I'm wondering, just maybe it's a little bit of foreshadowing, is do we have to embrace diagnosis on some level to effectively serve as primary care providers?
Yeah, I think so. And this is one of those terms that I think we have been a little afraid of embracing because, when I went to PT school 20 years ago almost, it was like, no, PTs don't diagnose, right? We treat conditions, but we don't diagnose. And I certainly feel like that's evolved. We have to diagnose. Again, not disease. I'm not diagnosing somebody's lung cancer, but I diagnose rotator cuff impingement, right? I think it's an interesting. Yes, to answer the question, I think we do need to embrace it. Again, and it's something we do all the time. It's not something new. We just have avoided the term for so long because like, oh, well, doctors diagnose and not PTs, but we do, right? I mean, low back pain, which is the diagnosis that you usually get from a primary care physician, is not a diagnosis, right? We evaluate it and we say, here's the physical therapy here's the musculoskeletal diagnosis, let's call it that, and then we treat accordingly, right? Low back pain is not a diagnosis. Oh, I guess maybe it is according to ICD-10, but you know what I mean, right?
Yeah, that's right. I mean, it's funny because I have seen, particularly I've managed physical therapists in the past where the doctor has a prescription that says, I don't know, facet joint dysfunction, right? And that's a certain ICD-10 or 11 code. And then the therapist will put down, let's say, lumbago. Like they'll actually just change it without actually thinking that, well, you did actually just change the diagnosis on that patient,
Mm.
which I'm comfortable with. And I think most PTs obviously are well within their scope and their skill and expertise. They're just interesting to think about, when there's a legislative change that comes, what are the potential other areas that we would need to support that? I know we're going to talk about some of that as we kind of get to the end. Before we do that, I think it's important to just discuss the barriers that physical therapists were facing in your state with regard to physical therapist practice and maybe access to care, because I believe those barriers exist in other states as well.
Mhm. Well, and that maybe is a good time to bring up. So we currently have legislation. So the next thing we're working on currently, Utah's legislative session is a 45-day session from mid-January to the beginning of March. So it's a part-time legislature. And what we're working on now is copay parity. So we've got this primary care designation, and so now we're trying to translate that in. Because one of the questions I've been asked often is, "Hey, so are you seeing better reimbursement? Are you seeing?" No, actually, we're not. Quite frankly, nothing has changed yet other than this definition, but it's the stepping stone to the next thing, right? And so one of the barriers that we're really trying to address with this copay parity is, when patients have a $25 primary care copay, but then they have a $50 specialist copay, and that's kind of at the far range. It can range anywhere in between, but that's a huge barrier to patients wanting to go to physical therapy because, maybe $25 initially doesn't seem like that big of a deal, but when we're talking 8, 10 visits, that can add up for somebody and it can be a deterrent to going to get physical therapy, which then it's just this cycle. And this is kind of the discussions that we've been having with some of the insurance lobby and the insurance providers is, look, you guys know that we save money when someone initiates therapy and sticks with their course of care. There's a lot of back end savings. And they've told us that they know that. And there's other issues that why they don't really support this legislation, mostly because they don't want to open the door to other professions saying, well, we're primary care, so we should get the copay. But to me, that I think that's one of the biggest barriers. And then the other one goes back to what we started with, and just understanding direct access and how patients don't need that referral to go to physical therapy. So helping the public understand, you hurt your knee, go to a physical therapist. You don't need to go to your primary care physician first. They're just going to send you there anyway. So save yourself the steps, save yourself the cost, and go get physical therapy first.
Mm-hmm.
So I think those are probably the two big barriers, is just that initial financial burden, but then also not understanding that they don't need to do that PCP visit first to get to the referral,
And it's always been interesting to me that we fall in between kind of this primary care place versus this specialist place to insurance companies, but yet they kind of, for lack of a better word, slap on this specialist copay, which can be a deterrent for patients to access our care, essentially.
Yeah.
And not too many other professions have that specialist copay, unless obviously it's a oncologist or a rheumatologist, things like that, and somehow kind of fell into that realm. So I think it's really good news that we can potentially find a way out of that. What's the impact for this for the general public? And I guess what role has the Utah physical therapy been taking to start to educate the public on what this change means for them?
Yeah, so that's, I think, the biggest challenge is getting that message out to the public. And so we've really tried to make a push once the legislation passed. We kind of came up with this little slogan of physical therapy is primary care. And we've really tried to get the private practices in our chapter to help push that message, because I think the challenge we have as a chapter is that when we talk social media, like all of our social media followers are chapter members, right? They're professionals, and we don't necessarily, and that might be something we look at in the future, is have a separate kind of public facing social media presence. But as of right now, it's all internal, more or less. And so we've really tried to help and support private practice owners in having materials, having a message to push out. Now, again, I think there's a little bit of a limitation there because the people are already there, right? If they're in the clinic, they already know this. But also at the same time, they may not know the primary care message. They know that physical therapy helps, but that primary care message. I mean, early on, we also, we did a couple billboards across the Wasatch Front. I saw one of our ads at the Salt Lake International Airport. So we did some marketing in terms of like trying to get the public message out to the public. But our big push really has been trying to support practices in spreading the word to their patients, who then will hopefully spread the word to their networks.
Yeah. Of course, with a change like this, it's going to kind of perk the ears up of some other providers. For example, primary care physicians, maybe a nurse practitioner, maybe a chiropractor, obviously the orthopedic physicians, and physical medicine rehabilitation always have opinions about how we practice. How can we use this legislative change as a tool to collaborate better with our colleagues instead of looking at it like we're creating undue competition in the market?
Yeah, that's a great question. And I think it just comes down to having the conversations. I think there's a lot of, in my experience, and I'm getting more and more as we go on, but it seems like there's always a lot of assuming going on, not only about like what the motives are, but also even just what. It's been a little surprising the amount of kind of information that's been portrayed as fact that's inaccurate, just in terms of our training, right? I mean, one of the initial pushbacks to the primary care legislation that we received was, well, you can't be primary care because you don't do wellness and you don't diagnose. Again, that's like 20-year-old plus thinking, right? But that wasn't, well, tell me about why you think you could do this. It was just like, well, this is why you can't do it. Well, you don't know. You haven't asked, right? And so that, I think having those conversations, but also explaining, I think the big thing is explaining the why behind it. And I think any family physician, any primary care physician, if you go in and say, hey, we're trying to do this to take the load off you and to increase access to patients, because nationally there's a primary care provider shortage. Utah is actually near the bottom of that list too. Like we're one of the most restricted states when it comes to primary care access. And so, and I think it's just easier said than done, but really it's not just like, hey, we're going to push this legislation. So here we go. But it's all of us that are practicing, especially in an outpatient clinic, but even those that are inpatient, we have relationships with physicians, right? Whether it's referral, just someone that refers to us or someone that has more personal connection, but it's having those conversations and educating those people as well. This is why we're doing this. We're not trying to take your piece of the pie. We're not trying to step on toes. We're trying to help. And we're looking at the publics and their interests really when it comes down to it.
What's interesting to me is that with a couple of words that change, it almost helps our colleagues start to develop a different professional identity about who they are, the power of their education and their license, kind of the depth and the breadth of their ability to reach people in their community. I think especially, I've heard this from people who work in more rural areas, how important this might be. And I'm sure Utah has a number of rural areas that could benefit from this, but it's just really an interesting, identity change for us as a profession.
Yeah, it really is. And I think that, I was just having a conversation with somebody last week about like having just for as much as I love physical therapy, physical therapists, I think there's a little bit of traditionalist mindset that we have for whatever reason. And like I said, kind of the pushback of like, I don't want to be primary care, that I don't want that responsibility. I don't want that. But here's another example is another current legislation we have this year in the legislature was a scope expansion. And I could talk a little bit more about kind of the process of that. It wasn't us that pushed it. It was actually an office within the state government. But one thing they recommended was adding the ability to order labs as physical therapists, right? And the sponsor of the legislation called up two PT acquaintances that he had, and both of them said, I don't know why I would ever do that. I don't know that we need to do that.
For those of you that can't see me, I'm shaking my head over here. The
Right.
reason
And that's
it's actually, the answer is really simple. And the answer is because metabolic disease has a bidirectional relationship with musculoskeletal conditions. So yeah, you want to know your patient's A1C. You want to know their fasting glucose. You want to know all their basic metabolic values. It has value, no pun intended, it has value in shaping the care that you're going to deliver to your patient. It's really interesting to me that some physical therapists have that language and others, I think because they're maybe potentially, I don't know, you can help me out here. Maybe because practicing in a more narrow way that they haven't started to consider, that could be something that's really beneficial. And by the way, patients love looking at their labs.
Yeah. And that's
When you can put a lab result in front of a patient, it changes the relationship that we have with the patient really fast. And because I've done that kind of work with people.
Yeah, and that's the point I wanted to make is I think that's maybe one of the biggest things that needs to happen within the profession is be a little more, some need it more than others, but to be forward thinking, right? And just exactly what you said, like just because you practice in this kind of little more narrow way, the rest of the story is because of that input he received, he pulled that from the bill. So two people that said, I don't know why I would ever do that, affected the whole thing, right? And all they would have had to do to say, rather than, I don't know why I'd ever do that, was maybe say, interesting. I could see maybe how that could be beneficial, right? Or just tweak the mindset a little bit rather than saying, why? I don't think I'd ever do that, to saying, why not? What could that do? I might not do it myself. And that's something we're trying to really emphasize is just because you individually don't feel comfortable maybe doing that, great, you don't have to do that, but don't limit it for everybody else with kind of this traditionalist, a little more narrow, like you stay in your lane, which is great, but don't limit others. with it. And that's one of the big frustrations we kind of run into with this.
It's really unfortunate that that was pulled like that. I was excited just for a moment, and it sounds like that maybe needs to be revisited next year again in a different way.
Yeah. Yeah, maybe.
Can you give us a window into what else the Utah Association is working on as far as primary care, scope changes, and just
Mhm.
things happening in that state that might be unique that other states can learn from and parlay off of?
Yeah, so like I mentioned, we've got this copay parity bill, which would more or less mandate that insurances charge the primary care copay for physical therapy versus the specialist copay. Utah legislature doesn't love mandates, so we're expecting a little bit more of a uphill battle. And like I said, the insurances aren't loving it either because they're a little concerned that it might open the door to somebody else. It's this big like nebulous the what if, right? So there's always that concern. And then like I mentioned, we have this scope change that was in Utah. There's a department or an office called the Office of Professional Licensure Review. I would call OPLR for short, and they're tasked with reviewing every licensed profession's scope and making recommendations of whether to add something or take something, making sure their scope matches the training more or less. And I've personally kind of really appreciated the process because it takes a lot of the pressure off of us because they're very thorough. They do their research. They talked with multiple stakeholders and they're open to feedback. There was one instance where they came back and said, okay, here's the recommendations we came up with. And we said, wait a minute, where'd you get that information? I mean, all specifically. So the things that we're looking at with our scope change now, and again, we have, I don't want to say we got lucky, but this has taken away some of the challenge because these things aren't being proposed by us. It's being proposed by a third independent office to the legislature saying, these are just things to consider for physical therapy. And it's not just us, it's us, OT, athletic training, nurse practitioners, physician's assistants. There's a big kind of group of professions that they looked at. So what we're hoping to see with this legislative session that really kind of aligns with primary care, and which I think is probably doing this last year helped with this, as this office looked at what their recommendations might be, is right now we can order imaging in Utah, but it's limited to X-ray and MRI. So we're hoping to remove that limitation and just have unrestricted imaging, the ability to order any imaging. Another thing in there is talked about these so many times, you think I wouldn't blink on them, but there's imaging. Like I mentioned, we did have labs in there, but unfortunately that got pulled. There was, we're updating the definition of dry needling because right now Utah's definition still has trigger point in there. And so we're trying to just align that with FSBPT's definition that takes trigger point out of it. We're also updating supervision not requirements, but supervision ability. Right now in Utah, a PT can supervise 3 FTEs between aides and PTAs. So you do the mental math on however that works out, right? But they're recommending, which is we have full support of, is changing that to 3 PTAs and 2 aides. So just more clearly defining that and expanding it some, because again, when you mention access to care in rural areas, that can be huge for a practice, being able to have more PTAs being able to be supervised for patient access, right? And then the final one is in Utah, the definition of PTAs being able to do joint mobilization is very gray. So they're recommending kind of really clarifying in the Practice Act that PTAs are able to perform grades 1 through 4 joint mobilizations. And that's the one where when they came back with their recommendations and said, okay, this is what we're recommending, and they weren't going to do joint mobilization. And they said, PTAs don't have the education. There was me and another person on the call who's a PTA program director. I teach in a PTA program. I teach the orthopedic content. We said, wait a minute, who'd you talk to about that? Because they do learn it. We're the ones teaching it to them.
Right.
And so, okay, great. We'll go back and look at it. And then they came back and they're recommending it. So I appreciated the process of them being very open and to all the feedback and looking at all the research, saying what are states doing? What is what's the phrase now? Basically like how much harm is done by PTs and PT treatment, which is very low. I can't remember the exact term, but those are all things that they looked at. And so I think the biggest one right now, we're hoping that one will kind of go through because again, it's this independent office that's recommended. We're getting a little mixed up with some disagreements with the PAs and the NPs, and because we're all in one bill. So hopefully that doesn't snarl things up too much. But the copay one is really kind of where we're we're planning a little longer. If it passes this, it'll be great and kind of miraculous if it does pass this session, but we're kind of planning that to be a multi-year thing.
What would your advice be to other state chapter presidents who are on the fence about this topic? They're not sure that maybe they want to pursue this as part of a change in their state, but obviously they see that the research is building in this area and other states have already changed. I think now there's been Utah. There's something that's changed in Montana and potentially maybe one other state. Is that right? Maybe am I missing a state?
Yeah, Montana's is a little different. It's not quite primary care, but they got recognized by workers' comp as
Treating
primary
physician.
care. So it's treating physicians. So it's a little more narrow, but I know they're using that to springboard into something bigger. And I don't know that off the top of my head any other state that's working on that specific. I've had lots of chapter presidents ask me about it, which is a good thing. I think what I would say is, first of all, don't be afraid of the fight, I guess. I don't mean that in an aggressive way, but like nothing changes until we try and change it. And it might not be, I know sometimes it's a little like, well, there's no way we're going to get that passed, so why try? Well, I mean, if we have that mentality, then nothing changes, right? Like sometimes you just got to take that first step and chip it away a little bit. Also, I think, again, I mentioned earlier, if you've been involved with APTA at a little, maybe higher level, you can see that they really are doing a lot to try and change payment. I mean, it's their number one strategic priority as of this year, right? Is payment. But again, they're pushing a very big boulder up a very steep hill. And if we can look at it rather than waiting for them to do it and then trickle down, if we can do it from a bottom up way. And so it's almost just kind of a team approach, right? Like, we know that together everyone achieves more. So if we can look and say, hey, if we slowly start picking this away at the state level, I think the number is something like if we get 21 states that can do it, then Medicare looks at it and goes, okay, we got to change it, right? Rather than APTA going, change it, and they just kind of brush them away. It sends a message, right?
This is important. I spoke with Emily Hurdon last week on the legislative changes that happen in Montana with therapists being designated as physicians under the workers' comp system there. The point you're making is actually her and I came to the same place at the end of the episode, just like we are here, in that really what you're saying is we need a coordinated message that
Yes.
we carry through every state physical therapy association, every state legislature, and of course the APTA is helping with that in whatever way they can help with it as well.
Yeah. And I think it's just to reiterate, like it's not well, APTA is not doing anything, so I guess we better do something. It's APTA is trying, but they've got a big mountain to climb. What can we do to help them?
Yeah. So the big mountain that the APTA is climbing is that would you say they're trying to change something in one fell swoop with the federal law, where obviously what you all did there is through state laws. Is that correct?
Yeah, I would say so. And I don't want to oversimplify what APTA is doing, but APTA has been for years advocating with, trying to change the therapy cap and trying to increase reimbursement. And I think,
Medicare.
again, if we're Medicare. Yeah. And as we know, where Medicare goes, everywhere else tends to go as well, right? And so again, if we can get this kind of primary care designation in multiple states, that's when Medicare is kind of forced to look at it and make hopefully a change at the national level, which then opens it up for everybody and decreases the barrier to access to everybody, right? And all the administrative burden. And that's kind of part of what it comes down to, is not just the recognition, but increasing access and decreasing administrative burden to make it easier for patients and for clinicians to provide care. Yeah, Joe, there's another important point I'd like to make about this topic. I think that as a profession, we need to stop defining ourselves by scope and start defining ourselves by education and training. Just last month, I was on a panel with a military PT. We were talking about primary care physical therapy, and he said something that really stuck with me. He mentioned that in the military, they practice to their training, not what someone else has decided or legislated what they're allowed to do. They've been doing primary care PT in the military since the 70s. The way he said that really resonated with me. And I think it's something that's worth spreading and that we need to think about. Our training, I think our training equips us to be primary care providers. We're educated in many skills that often we're not allowed or encouraged to use. So, for example, take lab work that we've talked about. We received training in PT school about how to, lab values and how to interpret those values. It may not always be, kind of the top of our mind as clinicians because it might not be something that we're doing often and maybe feel fluent in, but it is part of education and our professional preparation. The point I made about the bill, the OPLR bill we talked about in PTAs. PTAs in our programs here in Utah, not just our program, but in the other educational programs, they're educated to perform grade 1 through 4 joint mobilizations. And so another entity attempted to claim they weren't, but because we advocated for what is actually taught to our students, those skills are now hopefully being formally recognized in PTA scope in Utah through these legislative changes that we've talked about. So I think ultimately this is about shifting the narrative and shifting our perspective. We should be advocating to practice what we're educated and trained to do and not settling for what others think, what others decided that they think we should be able to do through legislation and scope. So, I hope that makes sense. And that's something I really feel is something that we can focus on as a profession in order to move things forward.
Yeah. So that's interesting. And I want to, maybe you can help me kind of bring a real life case to this, a real life scenario. So over the last couple of years, Medicare has released pain management codes. They're at G3003 something. And there's a 30-minute code and there's a 15-minute follow-up code. And those codes are for things like pain literacy and health behavior change, things that obviously fit squarely within our scope of practice.
Mm-hmm.
The kind of sticker with those two codes is you have to be designated a primary care provider under Medicare to bill out for those codes. So physicians can use it. I believe PAs and nurse practitioners can use it. And of course, the people who are probably doing the most pain literacy or pain education and health behavior change are us, physical therapists.
Yeah.
But we're excluded from those codes. So kind of what you're saying is if we can start to get a grassroots movement in different states where we get some kind of designation as primary care, then we have some real leverage to go to Medicare and say, hey, this is what we do. And now it might actually in some alternate way open up reimbursement and billing pathways as well.
Yeah.
Yeah.
Yeah, I think so.
Yeah. So brilliant. And, I really appreciate all the work that you're all doing there at the Utah Association. And I know it's having an impact on the other states. I know that all our listeners and followers will share this information. If people want to learn more about you or they want to contact you, how can they reach out to you?
Yeah. So if there's any questions or anything, then they could email me either at president@aptautah.org or also my personal email is jcarrierdpt@gmail.com. I'm happy to answer questions. And again, I always feel a little self-conscious because our path was a little different than others might not have that same path. And so, I might not have some, hey, do it this way, but if nothing else, my hope is that what we kind of mentioned, like looking at the bigger picture of, give it a try. And even if it fails, try again. And that gives momentum to everybody, I think, do it.
Excellent. So I want to thank Justin Carrier for being here this week on the Pain Science Podcast. Those links he mentioned will include on the podcast page at the integrativepainscienceinstitute.com, where of course you can just hit reverse or rewind on your podcast player and access them as well. Obviously, if you're a physical therapist, this is important information. Please share this with your friends, colleagues, and patients so they can learn more about the importance of primary care physical therapy. And obviously share this with your friends and colleagues at the university or within your professional association as well. I want to thank Justin again for being here with us this week, and we'll see you next week.
Thanks, Joe.
Thank you for listening to the Pain Science Education Podcast. To subscribe to the podcast and learn more, visit integrativepainscienceinstitute.com. That's integrativepainscienceinstitute.com. Sign up to receive weekly updates and learn about our continuing education courses. If you enjoyed this episode, leave us a review on your favorite podcast platform and share this episode with your friends. Please join us next week as we share more science-backed solutions for treating and reversing chronic and persistent pain.